Thank you very much, Dr. Georgie Abraham, for taking us to the inauguration of our virtual conference 2021. Without further delay, let's move on to the first session, which is one of the most important sessions for this conference, patient advocacy. In this session, we have an esteemed set of doctors to address us on most important points that the country is waiting to hear. In this panelist, we have Dr. Vasanthi Ramesh, bringing together the role of a patient to bring one unified system in India. We have a nephrologist, Dr. Sanjeev Gulati, to talk about what are the changes needed in the organ donation laws. Followed by Dr. Umali, who's talking about children on the journey of CKD and the changes needed in the laws and the privilege that should be given to our Indian babies to lead better lives on CKD. Last but not the least, we have Dr. Sanjay Agrawal, who's going to be talking about the expansion of the relative category and how we could use the current existing laws better to make organ donation to the best use for every patient waiting on the waiting list for a transplant. So may I request our doctors to please take over.
Good morning, friends. I'm Dr. Vasanthi Ramesh from Delhi, the founder director of NOTO. It's a very pleasant moment to join all of you along with the Kidney Warriors Foundation, a very apt name, who are fighting for patients who have kidney problems, which warrants a transplant due to end-stage renal failure. And I was asked to talk about the patient's role in bringing one unified list in India. And I was delighted to have this as a topic for discussion. The Transplantation of Human Organs Act, enacted in 1994, and its amendment, the Transplantation of Human Organs and Tissues Act, the amendment made in 2011, have made sweeping changes to enable transplants, to curtail commercial dealings and illegal dealings. So the amended act stipulates a national network in its clause 13C and elaborated in the rules formed thereafter in 2014 in Rule 31. Also, a national registry has been proposed in clause 13D and elaborated in the rules. A single unified policy of allocation is also very clearly laid out in Rule 31, Sub-Rule 4. So what does the national network have to do? The clause 13C of the TOTA states that a national human organs and tissues removal and storage network has to be established by the central government by notification, and also regional networks in such manner and to perform such functions as may be prescribed. And the Rule 31 of the Act talks about the manner of establishing national or regional or state human organ and tissues removal and storage networks, as well as their functions. It states that a national networking organization and also the regional and state networking organizations may be established by a notification by the center. And more importantly, that the state units would be linked to hospitals, organ or tissue matching laboratories, and tissue banks within the area on one hand, and also to the regional and national networking organizations on the other. And what about the national registry? There has to be a single national registry. The reason for using the term single will be appreciated by you all later. The clause 13D of the Act specifies the establishment of the national registry. The central government shall maintain a national registry of donors and recipients And such registry shall have the information as may be required to an ongoing evaluation of the scientific and clinical status of human organs and tissues. And the Rule 32 elaborates on the information to be included in the National Registry regarding donors and recipients of organ and tissue. So it states that the National Registry shall be based on organ transplant registry, organ donation registry, tissue registry, and pledge registry. And this registry will be accessible online through a dedicated website. The registry will not reveal the identity in the public domain of the individuals and ensure security of all collected information. And this information to be included shall be updated as per prevalent global practices from time to time. Then we come to the single unified policy of allocation. As per Rule 31, Sub-Rule 4, the broad principles of organ allocation and sharing shall be as under the website of the Transplantation Center shall be linked to the SOTO, ROTO, and NOTO through an online system for organ procurement, sharing, and transplantation. The patient or the recipient may get registered through any transplant center, but only one center. And the details shall be made available online to the networking organization, who shall allocate a registration number, which would usually be a unique ID number issued by NOTO. And this would be same even if the patient changes the hospital, state, region, or anything. And the allocation of the organ to be shared is to be decided by the state networking organization. And in the case of Delhi, it is the national organization. Marianne wanted to know the organ allocation priority. And this is very clearly stated in Rule 31, Sub-Rule 4, D and E. All the recipients are to be listed for requests of organs from deceased donors. And the priority to be given in the following order: those who do not have any suitable living donor among near relatives. It will be the first priority. Those who have a suitable living donor available among near relatives, but the donor has refused in writing to donate, would be second. And those who have a suitable living donor available and who has not refused to donate in writing is third priority. The sequence of allocation of organs shall be in the following order. That is, first the patients on the state list, then those on the regional list, and then those on the national list. All these are for Indian citizens. Then this will be followed by persons of Indian origin. And lastly, if none of the above are available, then the offer would be given to a foreigner. The online system of networking is elaborated in Rule 31, Sub-Rule 4, F, which states that the online system and the framework and the formats of the National Registry, as per Rule 32, shall be developed by the Apex Networking Organization, and this shall be followed by the state governments or union territory administrations. The allocation criteria may be state specific, but they would be determined in consultation with the state level networking organization, that is the SOTO. The Rule 31 also states in the sub-rules 5, 6, 7, and so on, that the networking organizations shall coordinate retrieval, storage, transportation, matching, allocation, and transplantation of organs, and will also develop norms and SOPs for such activities. They would also coordinate with the respective state for establishing new transplant and retrieval centers, including tissue banks. And there shall be designated organ and tissue retrieval teams in the state, district, or institution, similar to what is available in the UK in the NHS. Networking shall be e-enabled and accessible through dedicated website. where we can take this as the NOTO website. And the reference or the allocation criteria would be developed and updated regularly by the networking organizations already available in the NOTO website. The networking organization shall maintain and update organ or tissue donation and transplant registry at the respective level. And it is important for patients to know that they have the right to appeal. Any person aggrieved by an order of the authorization committee rejecting an application for approval under section 6, subsection 6 of section 9, or any hospital or tissue bank, as the case may be, aggrieved by an order of the appropriate authority rejecting an application for registration under subsection 2 of section 15, or an order of suspension or cancellation of registration under subsection 2 of section 16, may, within 30 days from the date of the receipt of the order, file an appeal in such manner as may be prescribed against such order. And this to be filed to the central government when the authorization committee has been appointed under subsection 1 of section 13 under clause A of subsection 4 of section 9. And to the state government, the appeal will be filed when the authorization committee is appointed by subsection 2 of section 13 under clause B of subsection 4 of section 9. Another important thing which patients would like to know, whether they would have to pay for their registration as a candidate on the waiting list and for any other kind of registration. It is important to understand that as per the Act and the rules, there is no payment for registration of donor with the SOTO, ROTO or NOTO. So Form 1, 2 and 3 for near relative, spousal donor and non-near relative donor respectively, as per thought rules, makes no mention of any payment. Also, there is no payment for registration of a candidate on the waiting list with NOTO, ROTO or SOTO. Yet, however, payment is charged in many states under various heads. Only condition where payment is to be made is for registration of a transplant center. A new registration, 10,000 rupees payment is to be made. For renewal, 5,000 rupees payment is to be made as per forms 12, 14, 15 and 16. No payment is required for registration of a NTORC as per form 13. We will now see the state-wise distribution of the deceased donor organ transplant. The maximum activity is the dark green, where it is initiated and expanded, and most of them are the states in the south and the west. There are schemes in various states to promote kidney transplant, and these are some of the few. In Assam, they have a Sushrusha scheme, which provides 1 lakh for BPL patients. Assam Arogya Nidhi. Telangana and Andhra Pradesh have the Arogya Shri, which covers a large part of transplant for BPL patients. Tamil Nadu has been very successful by virtue of the Chief Minister's health insurance scheme started in 2012 by the then CM, Ms. J. Jayalalitha. In UP, the kidney and corneal transplant facility are proposed to be covered by the Ayushman Bharat scheme under PMJ. Karnataka has a Vajpayee Arogya scheme for those with BPL region cards. Gujarat has the Mukhyamantri Amrutam Yojana, which provides up to 5 lakh for kidney transplant and other transplants. So the National Registry established as per the Act by NOTO in comparison with the international registries. As I said, we do not get the outcome data from the states and the institutions. In contrast, in the USA, the UNOS, also part of a federal system like India, collects and reports data on every US organ donor every transplant candidate, recipient, as well as outcome. The data is used to study and advance transplant, inform policy development, and help professionals make informed decisions. The OPTN, or the Organ Procurement and Transplantation Network, has reported 40,000 living transplants. Hence, my dear friends, life is like a flute. It may have many holes and emptiness, but when worked on carefully, it can play magical melodies. As music is everlasting, even after a singer is no more, organs donated can be everlasting, even when life is no more. Thank you very much for a patient hearing. And I thank the Kidney Warriors Foundation and Ms. Vasundhara and Marianne for having given me this opportunity to share my thoughts with you and to bring forth to you the points as per the Act and the rules, which I hope would be really useful to all of you. Thank you very much for a patient hearing.
Hello, friends. I am Dr. Sanjeev Gulati, Chairman, Nephrology and Kidney Transplant, Fortis Group of Hospitals, NCR, and also President-elect of the Indian Society of Nephrology. I've been asked to talk today about organ donation laws, limitations, and changes required. Now, the Human Organ Transplantation Act, by which we are governed today, was first enacted way back in 1994 by the Indian Parliament. And no doubt that it was a big step forward in organ donation. However, at ground zero, the reality still remains dismal. The organ donation rate in India is a meager 0.01%. In contrast to countries like Croatia and Spain, which have rates close to 35%. And this is despite the fact that India has one of the highest road traffic accident rates in the entire world. And despite this, we have one of the lowest organ donation rates. So currently we require close to about 500,000 organs every year, about close to 200,000 kidneys, about 50,000 hearts, 50,000 livers. And the gap between the demand and the supply is increasing every year. Every year, 2 lakh new patients of chronic kidney disease are added to this pool. So, does this law requires change? Well, to answer this, I'll quote Sir Winston Churchill. To improve is to change, and to be perfect is to change often. And I think for a law that was enacted in 1994, this can't hold better. So there have been numerous facts. Let's try and understand why is this so. As far as the living donation is concerned, we are currently a small family norm. There is a rising prevalence of diabetes. There is the breakdown of the joint family system. And this has really cleared the pitch for life-related organ donation. So organ donors are getting hard to come day by day. I also told you that we have the world's highest road traffic accidents, but we are still not seeing organ donation rates even half of what are there in other countries. So in such a scenario, I think we should be thinking and aggressively advocating change. And I'll deal with it under 4 headings. Well, first of all, let's focus on the cadaveric donation, and I'll be talking about the opt-out model. From the live donation point of view, the issues that need attention are financial disparity clause, which is there in the Human Organ Transplantation Act, the concept of rewarded gift, which doesn't find mention, and last but not the least, I think we need to think about a regulated and paid unrelated donation as things seem to be getting worse day by day. So I'll start off with the opt-out option. So what is this opt-out option? Well, opt-out option is an option which is given to each and every human being or a citizen of a country who's more than 18 years of age at the time he applies for a driving license. And it is said that, I would opt in as an organ donor. And if there is no consent or available, I mean, if there's no option available, then every road traffic accident victim who's brain dead and in whom we don't know his or her option is considered automatically as an organ donor without having the need to talk to the family at the time of the event. And time and again, transplant teams have been faced with the frustrating scenarios when the families or the near relatives of potential organ donors withhold consent for organ donation at the very last moment, sometimes totally oblivious of the donor's wishes. The emotionally charged atmosphere at the time of the event often precludes them from taking a rational viewpoint. So, in such a scenario, the Spanish model of presuming that all potential organ donors have opted in unless they have expressed their consent against it should be considered for our country too. Now, mind you, this model, although first adopted by Spain, has now been adopted by numerous other countries in Europe, like in France and Britain, as late as about a couple of years back. And they too have witnessed a dramatic increase in the organ donation rates. So I, for one, would strongly advocate for an, opt-out model. No doubt there are some drawbacks, but yes, every thought, every action has both pros and cons, and these need to be debated. Now, looking at live donation. So for live donation too, I told you that because of the small family norm, because of the breakdown in the joint families, a rising prevalence of diabetes, we are not getting donors from the family. Suitable donors who are medically fit are not available. So what are the options where we can increase the availability of organ donors? Well, the law, there's a clause in the law that we cannot accept a live donor if there's a financial disparity between the potential recipient and the donor, which I think needs a great deal of rethink. Because there have been times where we have proven that the potential donor is genetically related. The HLA has been done, and the only reason for rejecting the donor has been because they found that there was a gross disparity in income. So some sort of incentivization should be done, and this clause needs to be removed. There is this concept of rewarded gift, which is now being increasingly adapted in a lot of countries in the West. The concept of rewarded gift means that it is fair to compensate the donor for the time that the donor spent and the loss of work that he has to go through once he starts the process of gets into the process of organ donation. It's a time-taking process. You have to make numerous visits for investigations. You have to present yourselves before the committee, not once, but number of times. Then you have the surgery. Then you have the post-surgical issues where the donor has gone through a surgery. You can't expect him to get back to work. So the family suffers from loss of income of the donor on this aspect. And this aspect, I think it is only fair that is, we have to encourage live donation. We need to compensate the family for the loss of income that has incurred. And none of these two issues, the financial disparity, as I said, is a negative there. It is very much there in the law. And the rewarded gift also does not find any mention at all in the Human Organ Transplantation Act. So it's, I think, high time that we get together and we push for these two clauses. The third clause is even a bit is a step ahead, and that is the regulated and the paid unrelated donation. And this is also called the Iranian model. So what they have in Iran is that all the potential organ recipients register themselves with an NGO. Not only that, at the time of registration, a certain fee is levied on the potential recipients in lieu of the for the entire process, and also part of this fee is given to the potential to the organ donor as a compensation. And not only that, the fee is also used to provide health insurance, lifelong health insurance to the organ donor. So the potential organ donors to register with an NGO, and similarly the potential organ recipients. There is the recipient's family pays an X amount of fee, which is decided by the government, and everything is done in a very transparent manner, and the entire process is legal. So this ensures that the the needy people do get organs, and at the same time there are those needy people who are giving these organs are compensated to some extent. Now this does go against the principle of altruism, but so far we have not seen altruism coming forward in a big way or making a change. So if we have to move forward, I think it is high time that we think about these four options that I discussed. The opt-out model for encouraging cadaveric organ donation, making sure that the financial disparity clause is removed, putting in place the concept of rewarded gift, and finally, also thinking about the regulated and paid unrelated donation. And I'm sure that these changes will go a long, long way in bridging the gap, bridging the need and the demand gap. So I end on this note by Robert Frost, that a lot has been done, but a lot more needs to be done. And we have miles to go before we sleep, and we have miles to go before we sleep. Thank you.
Hello to everyone listening. I'm Dr. Umali. I'm a pediatric nephrologist. I've been practicing pediatric nephrology for almost 40 years now. And I'm currently affiliated to Leelavati Hospital for Children Hospital at Mumbai and SRCC Children's Hospital also at Mumbai. What we're going to talk about today is the privileges that children require when they have chronic kidney disease. Now, to understand what's chronic kidney disease, over time may progress depending on the underlying disease and its response to treatment, may progress over time with decreasing kidney function. And when this kidney function becomes less than 20% of normal, we call it end-stage kidney disease. We call it end-stage kidney disease because now the kidney is so low that the child cannot survive for long without a kidney transplantation or dialysis. We call it end-stage kidney disease. Now, increasingly, what we are seeing is more and more children coming with chronic kidney disease with less kidney function and who slowly progress to end-stage kidney disease. Now, this is, say, much more than what I would have seen, say, 20 years ago. And there are many reasons to it. One is there are more pediatric nephrologists in the country now. 20 years ago, there were just a handful. Today, there are more than 200 pediatric nephrologists. So there are multiple centers across the country where children with such problems can be handled, and so the referrals are more. There's also increased awareness in pediatricians who look after these children primarily about kidney disease and how to recognize it, when to refer, etc. So that is another reason why we see more. And third, a very important one is that most pregnancies in most places, there is an ultrasound done during pregnancy. And this detects many kidney abnormalities in the unborn child. Now, all these kidney abnormalities don't become chronic and kidney disease because you have a very advanced now neonatal care. So many newborn children, premature children who would not have survived earlier are now surviving. But sometimes these kidneys are not very well developed kidneys. They've also faced a lot of stress during the NICU stay. So over several years, some of these children, not all of them, but some of them will go into kidney failure. Similarly, you have very excellent pediatric intensive care units now. So many children with critical illnesses do survive. So many of them develop some kidney injury during the critical illness, which resolves initially, but some of them in the long term may go into kidney failure. And cancer survivors similarly have a problem because some of the chemotherapies we use may be toxic to the kidney. And there's widespread use and misuse of many drugs, both allopathy and non-allopathy, which can be harmful to the kidney. And these in India are available over the counter and often self-medicated or given by parents, which can have a toxic effect on the kidney. So there may be both a true rise in data of how many children do we have in India who are facing end-stage kidney disease, and how many of them really receive dialysis or transplant and what happens to them. We are right now, the Indian Society of Pediatric Nephrology has just initiated this year a national registry to record these events. So at some point in future, we may have a clearer idea, but just a extrapolation from what we know in Western countries. The incidence of end-stage kidney disease in children is anywhere from 15 to up to 60, 70 per million population. Now, converting that, we would say that in Maharashtra alone, we may have somewhere between, you could say, 1,500 to 3,000 children who have end-stage kidney disease. And in the whole of India, this may be 25 to 50,000 or more. This is a very, very rough guess. Now, it cannot sustain itself, and the child would die if we don't offer some better therapy. The best therapy we can give is kidney transplantation. So when we give a new kidney to a child, any adult who's healthy, who has 2 healthy kidneys, who does not have any heart, liver disease, these all tested before transplant, can very safely donate 1 kidney because we do not need 2 kidneys to survive to another person. But the gaps we get in this, one is that there has to be a compatible blood group. Just like your blood transfusion, you cannot give any blood group to any person. It has to be a blood group which is the same one or which is compatible with the patient. So that is a primary requirement. And donor's health is an important thing because we cannot put the donor's life at risk or health at risk. So it has to be a healthy donor. So many times when we investigate, although the person may seem not be really in a position to donate, even though they may want to donate to their child. So many children, even though they, now if we pursue the transplant path, supposing the parents are healthy, but their blood group is not compatible, we can do what is called an ABO Incompatible Transplant. That means the blood groups are different, but we can still for 2 to 4 weeks with very focused with therapy, which makes it a very expensive process because whatever is your transplant cost, this is going to multiply that cost at least by 1.5 times, if not more. Second, some of these therapies themselves are slightly toxic, so that exposes the child again to more toxicity than he would if he was getting a plain ABO. The option for the child is get a kidney from a deceased donor. That means somebody who has died by various laws which have been thought out and periodically streamlined. And it is a list which is with the Zonal Transplant Coordinator Center, which is set up by the government, so that all the people who need a cadaveric donor, cadaveric kidney or cadaveric organ, can get themselves registered there. And so it will go numerically as a first come, first serve process for each different blood group. So A, B, O, AB are classified separately into 4 groups, and each group has a number from 1 to whatever number is there. At present, there is no clear priority for children to be higher on the list. So the average waiting time for a cadaveric transplanting period for a cadaveric transplant is approximately 5 years, if I take the average. There have been few patients who've been lucky enough to get up within 1 year of waiting or 1.5 years of waiting, etc. But most people have had to wait for very long. So I'll give you an example. And during that time, what they can opt for is only dialysis, because they've already reached a stage where they cannot carry on without transplant or dialysis. Transplant is not feasible, no living donor feasible. So the only option is dialysis. Now, dialysis in children is not so easy as dialysis in adults. There are many dialysis centers for adults. Even in small district places, you would have a dialysis center where they can handle 15 to 20 adults, and which are looked after by the dialysis technicians with an adult nephrologist visiting the center periodically and not really being there all the while. This cannot be done for children. Okay, children, if they need hemodialysis, which has to be done, it has to be based in a hospital where there is a pediatric nephrologist, because children may have many ups and downs during dialysis, and they would need immediate attention by a nephrologist or a doctor in attendance to take care of those problems. So it has to be hospital based. It has to have a pediatric nephrologist. As I said, there are only 200 pediatric nephrologists in India. The nurses trained in pediatric dialysis are even more scarce. And it's very difficult to get, a fistula made for a small child. So they have to have catheters put in their big neck veins. And the care of these catheters has to be very, very stringent. If you don't take care of the catheter well, you'll get an infection. And it's not an exaggeration to say that many children who are getting hemodialysis outside pediatric nephrology institutes die of infection. This is not an exaggeration. Okay? Or they acquire viral infections like hepatitis B, hepatitis C, because the overall asepsis requirement, etc., for the dialysis unit is not up to the mark. So that will hamper their subsequent chances of getting a good transplant. So there are a number of issues why hemodialysis is for smaller children who are below 12, 13 years is not really available except in few major pediatric nephrology centers. So the second type of dialysis which you have is what we call CAPD, where we put a catheter inside the abdomen. And this can be done at home because it's like a stomach wash. Fluid is put in the abdomen and drained out. It's simple. It's not difficult to do. So this can be done even by a patient who's living far away from a big city. But 3-4 issues again. They would require periodic checkup by a pediatric nephrologist. So there has to be access to that. There has to be access to somebody trained in managing CAPD complications, because they can get infections, sometimes catheter problems, and those are emergencies. And third is the cost. Okay, it is expensive. CAPD is not cheap and it's expensive. And as of now, there is no particular relief from the government in terms of, taking off the tax from CAPD or making it free for children below 5 years or 7 years, because it's a lifeline for them. But as of now, there is no such option away from Satara. And he was traveling almost 400 kilometers for coming for follow-up. And that child we put on CAPD because both parents had different blood groups. She was registered for cadaveric. But the cadaveric took a long time. And every time the child had a catheter problem, this man took the PD bag, sat in an ST bus, traveled overnight for 12 hours with a sick child. And it was just God's grace that the child didn't die on the way to the hospital. Luckily, each time we could treat her and get her out of it, but the father didn't give up. And this he kept on for 5 years, and she finally got a cadaveric transplant some 7 or 8 years ago. Now she's a young adult doing well. But the point I'm trying to make is the difficulties the parents go through. Okay? This father had to leave everything and bring by ST bus, travel nearly 400 kilometers just to treat the infection in the peritoneal dialysis because there was nobody else to do it there. And the cost he must have spent, although the hospital didn't charge him, but for the peritoneal dialysis, it gives you 20% of your kidney function. The remaining functions have to be supported by medications, by injections to improve your hemoglobin, not allow you to have bony deformities, allow you to lead a healthy life, etc. Now, if the child is coming for hemodialysis to a center or to a hospital 3 times a week, plus taking this medication, so one parent has to accompany this child. So the parent loses wages on that day. The child's schooling is at jeopardy because how's the child going to go to school if thrice a week is coming for hemodialysis? And the cost of travel and other incidental costs, which we are not counting in the dialysis costs, which is itself expensive. Schooling goes for a toss. There's no recreation play activity for those children who manage to go to school, like pediatric centers like ours at SRCC and Vadia Hospital. We try to accommodate the school hours and try to get them different hours for dialysis. But if they're taking dialysis in a busy adult center, it is just not possible for them to adjust their timings for the children because they're overfull. So schooling itself is something which we have to keep. 5-6 years on cadaveric transplant, they lose all their growth years. And once their growth years have passed, even if they get a transplant, they are going to remain very short adults. So this also has a lot of social kind of impact of the lives they lead, their own perception of themselves, and various other issues that arise secondary to this. So if you look at all this, as it stands now, donor transplant, then children need to be given these special privileges. They need to be high on the list of transplant, which is there in many countries, that, children are given a higher number always, so that if a kidney becomes available and a child is on the list, they get priority. Because the child does not have time. If 5 years of his life he's going to spend in dialysis, he or she has lost a lot on the way, which can never be given back to them. So this priority is somewhat equitable so that we don't deprive adults as well who need it. Maybe one suggestion which is there is that every child who needs a transplant, the parents should be by default checked. And if the parents are not suitable, only then they should be entered for cadaveric transplant. So we don't fill it in with people where they have a parent who can donate. So where there is a parent who can donate, that should take priority. And for those who do not have a suitable parent because of blood group or ill health problem, should be put on the cadaveric list. And that cadaveric list should prioritize children. that children should be high up on the list so that the waiting period gets as minimized as possible, because of all the issues I said about dialysis in children. Okay? I'll just end with two examples. Now, it is our last option, so we not need to improve the other options for these children, like going for live donor transplant, compatible transplant, cadaveric transplant, by improving their chances for being higher up, which is something which a government needs to take note of. And some of the other privileges beyond transplant which we need is for dialysis. I think pediatric dialysis by default should be made free by the government, because it's a lifeline for these children. Especially CAPD, because that's the only thing possible if the child is very small, below 5 years. Hemodialysis you cannot do. It's the only feasibility if the child is living outside a major city which does not have a pediatric nephrology center. Then they should not even risk hemodialysis. They should go for CAPD. And unless CAPD is made free for young children, it's not going to happen. And we are going to be in the same phase what we are, where hardly 10% of the children who need this treatment are getting this treatment today.